So thank you everybody for joining us today. I'm Robin Fowler, Vice President, Philanthropy, Strategy and Campaigns here at St. Michael's Foundation. Without a question, we know COVID-19 has commanded the world's attention for the last 3 years. And now we're hearing talk of an 8th wave. At the same time, the World Health Organization has suggested that the end of COVID-19 as a pandemic illness is in sight. So no doubt you, like me and many others, have pressing questions about where we're at today with the virus and the latest vaccines. As we head into the fall and winter months, we wanted to take this opportunity to cut through the noise. And how very lucky we are that St. Michael's and Providence Healthcare have no shortage of experts on this front. And their efforts and those of our hospitals have been supported throughout the pandemic by our incredible donor community. So thank you very much. 2 of our leading experts are with us today to share their insights and answer your questions. Please note this talk is being recorded. You can ask questions under the chat function in Zoom or by raising your hands with the reactions function at the bottom of the screen. Now let's get right to our panel discussion. I'm pleased to turn it over to our moderator, Dr. Irfan Dhalla, Vice President, Care, Experience and Equity at Unity Health Toronto. Irfan.
Thanks, Robin. It's great to be here today. Thanks, everyone, for joining. It's a special day at St. Michael's. It's the Feast of St. Michael's Day, which is a day when we give out our Values in Action Awards at the hospital. So everyone is in a good mood, having celebrated that today. We have a great session today. 2 terrific speakers. I'm going to just introduce them, and then they're going to give a very brief presentation each, and then we'll get to your questions. So our 2 speakers, both of whom have had very senior leadership roles during the pandemic, both of whom have worked very hard and taken very little vacation. First, we'll have Dr. Fahad Razak. He's a general internist and an epidemiologist at St. Michael's and the former director of Ontario's COVID-19 Science Advisory Table. And then second, we have Dr. Matthew Mueller, an infectious disease physician, medical director of infection prevention and control. He's been a key advisor to the executive team at the hospital throughout the pandemic. He's also worked with his colleagues across the city and the province. And until very recently, he was the chair of the Provincial Infectious Diseases Advisory Committee at Public Health Ontario. Okay, we're going to get right to it. Fahad, let's start with you. What are you seeing and hearing out there?
Thanks, everyone. Really appreciate the chance to speak to you today. I thought I would start with just a very brief update about where we are in the pandemic. We've entered the fall season, and there was a lot of worry that this year is looking a little bit different than previous years in that we have a fair bit of virus already circulating as we enter of the fall and then eventually into the winter season. This is typically a time when you get more viral transmission because people are indoors, kids are back in school. If you look at our wastewater signal, this has become a really important way that we measure disease activity. So as a lot of you know, we started to limit access to our standard lab testing, our PCR tests for COVID infection, SARS-CoV-2 infection or COVID disease earlier this year. And because of that, we don't have as much of a reliable way of telling how many people are sick as we used to based on the number of positive tests. Instead, we've started to rely greatly on wastewater. This is fragments of the virus that are excreted in waste, and they can be assessed in terms of how concentrated they are at our wastewater treatment plants to give a sense of how much virus is floating around. And as you can see, as we enter kind of late September, we have this wave that occurred starting around July, and it hasn't really abated. So we're still seeing very high levels of virus floating around right now. And this is reflected in the fact that probably many of you know someone who's been sick in the last few weeks, who's had COVID in the last few weeks. So you can probably personally know this. And if you look across the province, we're kind of seeing this all the way across the province. There's kind of a plateau or even a rise. This may get worse as we have, just over 2 million children who came back into school in the beginning of September, including both my kids. One other way of looking at this is the number of positive tests that result when you do the PCR test. So the PCR tests are limited to higher risk groups or healthcare workers. The orange line is the number that are coming back positive. And as you can see, it's just under 15%. And again, it's kind of plateaued over the last few weeks, telling us that there is a lot of virus circulating. Now, the important thing is if you compare where we are now to where we were just a year ago, so summer, fall, just a year ago, our levels of hospitalizations and the number of tests coming back that are positive may be in the range of 5 to 10 times higher than they were just a year ago. So although many of us want this phase of the pandemic to be over, unfortunately, the data is telling a very different story. So I think I'll stop there. That's my quick summary. I wish it was more positive news, but it's the reality of what we're seeing. I'll say the one positive takeaway is on the bottom, on the left slide, on the left graph, if you look at the bottom line in dark orange, you'll see we haven't had a real rise in cases in ICU. This does tell us that the immunity that we've developed as a population, both through vaccination, most importantly, but also the fact that probably at least 3/4 of the population were infected by Omicron since the beginning of the year. Those two things together mean that as these new infections are happening, we're not having a rise like we saw earlier in severe illness. So that's one good point. One point of good news, which is that our immunity wall right now does seem to protect against severe disease.
Thanks very much, Fahad, for that overview of where we are right now. Matthew, can you tell us a little bit about what things are like at the hospital right now?
Sure, and my pleasure, Irfan. So I think what I'm going to talk about is really exactly what Fahad said, but focusing in at the hospital level. And so at both St. Mike's and Providence, we continue to have patients with COVID that are admitted to hospital, smaller numbers in the intensive care unit compared to earlier in the pandemic. What's really changed over time, I think, I'm going to focus on COVID first and then the health system in general, but we continue to have, every day we have staff that are diagnosed with COVID. Every day we're dealing with COVID. We continue to have some outbreaks on units across Unity Health and at Providence and St. Mike's. But there has been a shift in the type of patient. So early in the pandemic, the classic person admitted to hospital had respiratory failure from COVID pneumonia coming into the ICU. Over time, we're seeing a real mix of people. So we have some patients in the hospital who still have more severe COVID. We have other patients where COVID is interacting with their underlying medical illnesses. And between those two things, they're sick enough to require hospitalization, but not a pure sort of COVID illness like we saw earlier. And we also see people that just happen to have COVID, but in fact, that's not why they're in the hospital at all. And it doesn't seem to be directly related to why they're in the hospital, but it still is a challenge for the hospital because they require a private room and infection control precautions and can affect how patients flow through the hospital. So the pandemic continues to evolve and we continue to struggle with it in different ways as we're going forward. I think I like the wave analogy that's often mentioned. So we talked about a 7th wave and an 8th wave, and it took me a shockingly long time to realize that it really is exactly the same as an ocean wave. And once one wave hits you, if you're swimming and it starts to recede, if you turn around, the other one's coming up on you already, right? And I think that's what we're seeing with the wastewater signal and what we need to prepare for in the fall. And the other challenge for the health system from a pure infection point of view is that we are anticipating at least the possibility that we could have quite a severe influenza or flu season this year, which is based on predictions from what's happened in the Southern Hemisphere, where in Australia and New Zealand, for example, they had quite a severe flu season and a lot of issues in the healthcare system related to having both COVID waves and flu at the same time. And then the other analogy, moving away from waves, is I'm starting to think of it as like a boxing match. And so although the punches that COVID is throwing at us are getting weaker and weaker because of the immunity that Fahad alluded to, everyone who works at the hospital, our hospitals, has been vaccinated. Most have received a booster. Many have had COVID. And with our patients, it's the same thing. A lot of them have had COVID, vaccine, or both. And so the damage that COVID can do is dissipating to some extent, but the accumulated impact on the health system is really immense. And so our frontline healthcare workers are tired. We were talking just before the call about lack of vacation, and in some cases, they're tired of dealing with COVID. They're overwhelmed with the workload. The number of staff that we have has decreased. And this is not a problem that's unique to our facilities, but it's a system-wide problem. And so although the punches that COVID is throwing are getting tired as we get into the higher rounds, the healthcare system's ability and resilience is also weakening, right? So I think we're anticipating that this could be a challenging fall and winter season, and we need to do what we can to really protect everybody from from COVID going into it, because even having staff off now with a mild illness is a big problem for the system. So I'll stop there.
Thanks, Matthew. That was very, very helpful. And again, thanks for everything you have been doing for the hospital throughout the pandemic. A few questions have come in on the chat. Please feel free to put a question in there. And if, sometimes I think people don't want to ask a question publicly, please feel free to send me a personal message. That's I won't say who's asked the question if you do that. You can also put up your virtual hand on Zoom, or you can put up your real hand, and I will try to keep my eye out for them, although there are 2 or 3 screens of people. So if I miss you, the virtual hand will make sure that you come up to the top. Okay, one question that has come in on the chat. With the recent removal of masks on airplanes, how safe is it to travel now in that environment? Matthew, maybe I'll give that one to you.
Sure, and these are the toughest questions, and because I think the real question is, should I travel, right? And so a lot of the answer always comes down to your own risk tolerance, your own health, whether you're vaccinated, whether you're immunocompromised, whether you're older or younger, in terms of making these decisions. And then, of course, all the positive things that come out of traveling. So, one thing I think is true is that to some extent through the pandemic, we found that the ventilation on planes is protective, and planes maybe were safer than what we thought they would be at the very beginning of the pandemic. But on the flip side, through the whole pandemic, I don't think there's anything riskier than travel, because of a number of things that are associated with it. So you have to get to the airport, you have to get into the plane, you have to get where you're going, there's delays, and then usually on the other end, there's hotels and restaurants and behaviors that might be different than what you've done before. So, we have to think through all of that. And so I do think travel is associated with increased risk. But, we don't want to be in a world with no travel. So you have to balance, what can you do to protect yourself? So again, it's better protection when everyone's masked, but you can still wear an N95 respirator, KN95 respirator, or mask yourself, and try to do that consistently through your flight. You can try to avoid crowded areas on your way to and from the airport to the extent that that's possible. And of course, you can make sure that you're fully up to date with your COVID vaccination to minimize your risk of getting COVID and make sure that you don't get severe COVID if you do get infected.
Thanks, Matthew. Can I ask you a follow-up related question that's come in? Given that most people are not wearing masks around the city, you go to the mall, wherever, if someone is immunocompromised, how protected are they if they wear a mask, but the people around them aren't wearing a mask?
Yeah, I mean, I think it's a reality that the mask works in both directions. So it protects the wearer, and it also protects people around the wearer. And so, but I think we're not going to go back to any kind of situation where everyone is masked unless something really disastrous were to come in the future with, say, a different variant or something that was a real shock to us. I think this is the world we live in, where if you're going to be out in public, in stores, restaurants, etc., you're going to come across a majority of people that are unmasked. Wearing a mask protects you a little bit. Even when everyone was masked, it's not a foolproof protection. So at a population level, significantly reduces transmission of COVID, but it's absolutely no guarantee that you won't get COVID. And so that's the unfortunate reality. I guess to inject, try to be optimistic here. There are different forms of immunocompromise. Most people who are immunocompromised, like not to the most extreme degree, still will be at least have to have some protection from vaccination, and still actually even more important that they're fully vaccinated. And we do see people that are elderly, that are immunocompromised who have mild COVID. So it's very hard to predict. It's not that everyone will have severe COVID or a complication, but obviously your risks are higher, and you have to look at your own risk benefit analysis when you're trying to figure out how to navigate this world as we're sort of moving from pandemic to endemic.
For sure. Okay, Fahad, I'm going to send the next question your way. Are you recommending the new Moderna booster, and are there side effects from it?
I am recommending it. Maybe I'll just add one comment to the question that Matt just answered about immunocompromised. I would just add that we do have a treatment available in Ontario with Evusheld for those who are most severely immunocompromised. So if you are one of those people who is worried about your underlying health because you're immunocompromised, your ability to do things that you would want to otherwise day to day, you should speak to your healthcare provider around whether you would be eligible for Evusheld. So Evusheld is a medication that's given. It's antibodies that are given to prevent infection from setting in. So it's a preventative therapy, and it was designed especially for people, for example, who may not have a robust response to immunization. So if you're immunocompromised, you may not generate the antibodies that you need based on your immunization, and then Evusheld gives you another layer of protection. So to your question about the bivalent vaccine, so I am recommending them because they are the best we have, and we're in a period of increased viral transmission right now, as I showed in the presentation. So I did recommend the vaccines that exist in the summer, which were before the bivalent vaccines were available. The bivalent vaccines are a little bit better. They're not a dramatic improvement on the original vaccine, but the studies that we have available do show that they do have enhanced activity against the Omicron family of SARS-CoV-2. So the Omicron family is what raced into our country towards the end of last year and has dominated all of the viral spread that occurred this year, and has been responsible for a lot of the infections that occurred, for example, even in people who are immunized. This new bivalent vaccine was designed to have an additional component that targets Omicron. It's not the version of Omicron that's currently circulating in Canada, which is called BA.5. It's an earlier version, but it still has activity against BA.5. And what's really important is that it seems to have activity against all of the major Omicron viruses that are circulating. And there's a lot of people in the scientific community that think that then the next waves, if they are to occur, may be more likely to come from within the Omicron family. And so if you get this bivalent vaccine, which seems to have protection across all of the Omicron variants that are circulating, it hopefully will also give some protection against whatever comes up next. So this is the right time, I think, to get it. Now, specifically the indications. So it's people who are in certain categories. If you look at our national guidelines, it's the suggested duration of time between your last vaccination and getting this one is approaching 6 months. So we would say 5 to 6 months. It can be as soon as 3 months if you're in a higher exposure risk category. That's the same thing for people who've had a recent infection. So that would be the same recommendation. I would say that the specific decision, again, should be guided by your healthcare provider, but the recommendation from our national body was during a period of enhanced viral spread. That certainly would reflect what we're seeing in Ontario right now. We're sort of in that period. So if you felt comfortable getting closer to that 3 month line right now, I think that would be reasonable.
Thanks, Fahad. And side effects on the booster vaccine?
No different in fairly large clinical studies, no different than the original vaccine. So the short-term side effects, which are things like feeling tired, having a sore arm, maybe even a low-grade fever, no difference than the earlier vaccines that most of you would have received by now. In terms of major outcomes during the first 30 days, again, no difference between that and the earlier vaccines. And then, of course, when we talk about side effects, we're always saying against versus what, and versus what is getting infected. So I would say even these side effects, even though, you could feel not well for about a day or maybe up to 2 days, we have to compare that against the risk of getting infected. So again, I would say the side effects are relatively mild for most people, no different than the original vaccines that were available.
Thanks, Fahad. A question I have not heard before, and so maybe I will ask it of both of you. If someone has the bivalent vaccine from Canada, can we also get the US one? And if so, when?
I'm happy to start. Matt, why don't you go ahead?
Sure. So, I think that really follows on from what Fahad was saying. And just to re-emphasize, like getting a vaccine versus not getting a vaccine or delaying your booster if you've reached that 6 month point is not a good idea. So, if you're past the 6 months, especially if you're in a higher risk category, just get whatever booster is available for you to get, whatever is easier. I don't really think it's worth flying down to the States just to get a booster that might be the next one that comes here, get, slightly ahead of the curve. I think there is some immunological data that your response is stronger when your vaccines are spaced out a little bit. So I wouldn't recommend, getting the BA.2 booster here and then 3 days later, driving to New York and getting the BA.5 booster. So I think if you've been boosted here, a week ago, I think the appropriate thing is to wait 3 to 6 months, and these vaccines continue to evolve. There might be something new, there might not be, but then get the vaccine when you're due for your next dose, whichever one is available. Fahad, do you have anything to add to that?
Yeah, I would say for anyone who has already gotten the Ontario bivalent, definitely don't go get the US one right away because of what Matt said, which is that you need that gap for it to be effective. And actually, there's a worry that if you stack vaccines too closely, you can do more harm than good. So at least you should be waiting 3 months until you get your next vaccine. Then additionally, I would say that there's been a lot of discussion, and I think some people looking enviously at the US to say, well, they have the bivalent that's targeted to BA.5. Ours is an earlier version of Omicron, but because ours was an earlier version of Omicron, we actually have larger studies supporting its use. So the version that we have in Canada has been studied in a large clinical trial, published in the New England Journal, peer-reviewed, showing it's very safe, showing that it's additionally effective not only against the earlier Omicron variants like BA.1, BA.2, but against what's circulating now, BA.4, BA.5, that it shows effectiveness against those as well. The US version has not. The published studies have not come out yet on human studies for the US version of the bivalent that's available. So definitely, I would look at Canada's version and say this is a good option for us. Now, after the US version is evaluated in human studies, it may show itself to be better in some ways than Canada's version. But like much of the pandemic, I think you need to do what you can to protect yourself today with what is available, and then in the future, recalibrate and make decisions at that point. So in that framework, I think what we have today in Canada is an excellent option.
Yeah, I think the advice to get the shot that is available is generally very good advice. And, Matthew, would you say that applies to the flu vaccine? And there was a question also about whether people could get both the flu vaccine and the COVID vaccine at the same time, whether you should space them apart. What do you think, Matthew?
Yeah, so I think for convenience, it's absolutely reasonable just to get if you're in a location where you can get both at once and you're due for both, absolutely do that. If for some reason you've recently had your COVID booster, I certainly wouldn't delay getting your COVID booster if you're due for it while you're waiting for flu shots to become available. Although that is now just around the corner, so they're going to be here any moment. But it's also okay to do them in either order. So really the most important thing is to get both. And I think this is definitely a year where you don't want to skip the flu vaccine based on sort of, the future is hard to predict, but our best guess is that this will be a flu season where you're going to want to be protected by the vaccine.
A follow-up for you, Matthew. Someone has asked, is it a consideration that all of my shots so far, 4, are Pfizer? Can I still get the Moderna for the bivalent?
Yeah, I think, there's actually might be pros and cons, but again, I think it's pretty simple. You can take a Moderna having received Pfizer. It's not a problem that you were only getting Pfizer up to this point, but it's not a problem now to get a dose of Moderna.
Thank you. Okay, changing the topic a little bit from bivalent vaccines and flu vaccines and Pfizer versus Moderna vaccines. A question that was sent in the chat. Fahad, maybe I'll pose this one to you. We are hearing more about the risks of long COVID and also the risks of heart issues and ongoing lung issues. Can you comment on how frequent these are? Sometimes we hear about a 40% increase, and it might be helpful to understand the absolute risk as well as the relative increase in risk.
Yeah, so the evidence around long COVID is still emerging. I'll say there's a few things that are coming more into focus now. The first is that the rates were relatively high compared to what we're seeing now earlier in the pandemic when people did not have immunity at the time of their initial infection. So people who were infected before the wide scale availability of vaccines seem to have had rates of pretty significant risk ranging sort of up to the 10% range of all people who are infected. And they seem to have persistent symptoms at least now 1 to 2 years out. That's initially. But once we had wide-scale immunity available via vaccination, the rates of long COVID seem to be substantially reduced. Still a really important entity to consider. Still, I would say, at least for me, a primary motivation of not getting infected now includes the risk of long COVIDs, but the rates are significantly lower if you're vaccinated. So, and again, a strong reason to keep your vaccines up to date. Everything we know suggests having not only vaccination, but up-to-date vaccination reduces the risk of getting long COVID. Now, the risk for the organ systems affected includes the heart, importantly, includes the brain, includes the kidney, includes the liver, includes a diverse range of organ systems. The risk increases of 30 to 40% for cardiac conditions. As you said, they are a relative risk against a very low baseline risk. So what that means is, let's say that the risk of getting something is 10 cases out of 100,000. 10 people get it out of every 100,000 infected. If that 10 goes to 14 out of 100,000, you suddenly have a 40% increased risk of developing serious heart conditions. But as you can see, the numbers are still relatively low. So we're talking about 4 people out of 100,000 or 4 people out of 10,000. So the numbers are low. That is the case with most of the most severe medical outcomes that we worry about with long COVID, things like serious heart disease, serious brain issues like strokes or seizures, serious kidney disease, serious liver disease. Those are still relatively low prevalence. And again, I don't have an exact number because it depends on your underlying vaccination state, general health condition, et cetera. They're still relatively low. What I would say is more worrying is the dysfunction related to long COVID, which is much more common. So the severe fatigue, the brain fog, the breathlessness, the palpitations, these things can be very disabling, even if you don't end up with a diagnosed medical condition. It's not that you've had an arrhythmia or heart failure, but you're having palpitations, or you're very short of breath, or you're very, very fatigued to the point you can't work or care for your family. Those things are much more common. So unlike a relative risk of 30 or 40%, 10, 20, 30% of all people who develop long COVID, these are now bigger numbers, can develop some of those symptoms. And those are the ones I really worry about because they can be very disabling for people. They could mean, for example, in the first wave of people who are infected, when they followed them a year out, about 20 to 30% of all people a year out had not returned to full work capacity a year out. That's pretty dramatic. And that's what I think could be the more disabling legacy of these infections. It could be real impairments of home function, work function, ability to go to school, et cetera.
Thanks, Fahad. Matthew, maybe I'll give you the next question. Families. So given that so many children are not wearing masks in schools, my own 3 children are no longer wearing masks, I will say that. The first day of school, there was one kid, or maybe one of the 3 kids wore masks, but they have stopped. And I don't think anybody in any of their 3 classes are wearing masks anymore. How can families stem the spread of COVID when kids aren't wearing masks in schools, particularly if there are older relatives in the household or people are visiting older relatives?
Yeah. So again, our control here is limited, right? We can only do what we can do. My kids are split, so I think one doesn't mask and one does mask. And actually, I think most kids in his class, for some reason, are still masking. So it may still be dependent on the school and the teacher and the classroom. But again, we've been sort of banging the hammer on vaccination, and again, that's something that you can do, and you should do both. This is also for the at-risk relatives who are older; they should be vaccinated and boosted, but the children should be vaccinated and get the boosters that they're eligible for at their age group and at the time when they can get them, both for their own protection and to protect their relatives. There's some very basic, simple things we can do, like common courtesy to keep your kids home, of course, when they're sick, even if you haven't tested them or you tested them and they test negative for COVID on a rapid test. They shouldn't be going to school if they have symptoms. That's going to protect the other family's kids, but then you hope that the other families are doing the same, to protect your kids. And when relatives are coming over, of course, you might want to cancel those visits if anyone in the household has even the mildest symptoms. So again, we've seen lots of times it's a slight runny nose that's attributed to allergy in some of our staff, and then they get tested and it's actually COVID. So sometimes we have to just be flexible to move those visits around, and it continues to interrupt people's social lives and ability to visit with family. But if you want to be safer rather than sorry, I think that's something you can do. But you got classrooms with 30, 40 kids in them. They're not masked. There's definitely going to be a risk there. And those are the kinds of things that we can do, but it's not a perfect system. But again, I think I don't want to over dramatize this either, because although I'm 100% a believer in masks and believe that masks do work, they're not perfect either, right? And the kids have to eat and drink at some point, and the masks slide down. And so even before, when everyone was masking, you still have to do those other things. It was one tool. We have one less tool to protect us. So makes the other things, particularly vaccination, all the more important.
Yeah, I mean, I just want to emphasize that the vaccination point a little bit, because it's striking to me how low the vaccination rate is amongst children, particularly young children. And, I think early in the pandemic, it became clear that the disease was much more likely to result in hospitalization or even death among older adults. That's obvious. And I think, many of us sort of breathed a sigh of relief that the disease wasn't, killing young children left and right. But it still can be a serious illness in children. I think there have been more than 1,000 children in Ontario hospitalized with or for COVID. Sometimes it's a little bit hard to tell with or for, but certainly lots of children in emergency departments, lots of children quite ill, and lots of children hospitalized. And there's no doubt that vaccination of children reduces the risk of those serious outcomes. And so, for those of you who have unvaccinated or under-vaccinated children or grandchildren, I think one thing you can do is really encourage folks to get your children vaccinated. Matthew and Fahad, would you agree with that, or anything you'd add to that?
Yeah, I would just add that most of the physician parents that I know have had their children vaccinated. So if that tells you kind of our vote of confidence in these vaccines, including, I'll say from me, both children under age 5, I had them vaccinated before they went back into school. And is it perfect? No, but I think at this stage of the pandemic, to me, there's few black and whites left. It's about risk reduction wherever you can, and getting them vaccinated is one additional layer of protection. It's not perfect, but it's what we have available to us. I like Matt and Irfan, I've also tried to have my kids wear a mask. I don't know how reliable it happens. I kind of tell them and they make their own decisions, but you do what you can.
Yeah. There's a good question about long COVID in the chat. Where can I get help with my long COVID symptoms? Exactly as you discussed, Fahad. It's great that these effects are being acknowledged, but has anyone specialized in helping with this syndrome? I'm 67 and I feel 80 despite doing physio, massage, exercising, etc. Fahad, maybe you first, and then I might add something.
Yeah, I'm hearing a lot of these stories. We did a large body of work on long COVID for the Science Table, and we just got an outpouring of stories from patients about the symptoms, and it's devastating to hear. I think the seriousness of how badly it can affect people is under-recognized. It's, as I said, for me, it's the thing I worry about the most for getting infected. Are there resources? We are behind. Ontario is behind in terms of having resources up and running. There is a push in government to get a clinic referral system in place. There are some clinics, for example, in both clinical assessment and physiotherapy. I know, for example, there is one at UHN. I want to defer to Irfan and our St. Michael's leadership about whether there is a specialized clinic available at St. Michael's yet. But there is an assessment center. A lot of this will have to be managed through family doctors because of, I see Irfan's put a link up, so I'm going to let him describe that. A lot of this has to be managed through family doctors because of the number of people infected and the number of people who have developed long COVID. The hope is that with what the government puts forward, there will be a referral network where primary care physicians will have enough information to do the first round of assessment, which would hopefully cover most people. And then for those with more significant symptoms, unusual symptoms, they can go into the referral pathway to some of these specialized clinics. That's the model that's been used in other parts of the world as well. But as you can see from how stretched our healthcare system is, both in primary care and acute care, there isn't a lot of capacity right now to deal with a lot of people having a new condition like long COVID. And that's, I think, one of the significant worries in terms of high quality care delivery.
Todd, one question came into the chat as you were speaking. Is there a definitive test available to confirm long COVID?
There's not. It's a clinical diagnosis, and it's not an easy one. It's a clinical diagnosis. Clinical diagnosis means it's a diagnosis that's made by a clinician using an assortment of symptoms, risk factors, and findings all together to make this judgment call that what you have indeed is long COVID. Unlike, for example, diabetes, where we do a blood test for you and we say either you have it or you don't. For long COVID, it's the combination of infection, the timeline since the infection, the kind of symptoms you have, plus eliminating other health conditions that could explain what you're presenting with. So, for example, if you're very breathless 8 weeks or 12 weeks after an infection, could it be long COVID? It could be, but we have to rule out heart failure or lung disease or anemia, other things that can make you feel breathless. So you have to eliminate those things. And then when you're left with no underlying explanation plus an infection in the timeline, we then start to suspect that it's long COVID. But even that story tells you why this is a labor-intensive process, right? You have to see a physician. There has to be a battery of tests, consistency of symptoms. So it's not an easy diagnosis to make. And that's where, again, the resource part of this is a concern.
Yeah, I put a referral form into the chat. So we have, under the leadership of Dr. Ashley Verdun and Melissa Mori-Hollis, we've established a clinic at Providence. It's an excellent clinic, actually. It's interprofessional, multidisciplinary, holistic. You can actually sort of get that sense even looking at the referral. The preliminary reports from patients who have gone through that clinic are very positive. They've had good experience with the clinic and good outcomes. I think the challenge with the clinic is it's oversubscribed. The number of patients who would like to be seen in that clinic exceeds the capacity to provide care. And as Fahad kind of alluded to, there is, not a lot of clarity on ongoing funding, as I understand it, from the government at this time. So, part of the reason why we need the foundation so much is government funding doesn't cover, as you all know, a lot of what we want to do in healthcare. Follow-up question on long COVID, and then we'll maybe go to a different topic. If you aren't able to get a test to determine if you have COVID, how would you be able to prove you have had COVID, I guess, to get into a long COVID clinic?
So right now, most clinics are accepting symptoms that were consistent with an infection, for example, with known exposure. And or a rapid test to establish that you had it. So for most people, I would say if you think you have COVID, it's worthwhile doing a rapid test. It'll help you with your decision making. For those of you who are in higher risk categories, there's a very important medication called Paxlovid, which is available to you. There was just a CBC article this week that it's being dramatically probably underused. We have a huge availability in this province. It is effective. And so you should get a rapid test. That rapid test is also part of your story for if you develop symptoms that could be consistent with long COVID. That said, there has been some contestation, for example, in the United States between insurance companies saying that they need more objective testing to say that you were initially infected. So again, if I had a fresh new infection, I would get at least the rapid test out and document that with my family doctor, get it into the medical notes that you had an infection, so that if then 8, 12, 16 weeks later, you start to develop symptoms, there is now a paper trail showing that you in fact did have something that could be the precipitant.
And maybe if I could just add to that, I think there was, Fahad, you answered a few questions in the chat, I think, about rapid tests. And so, just wanted to remind people that the rapid test is an okay test. It's not a great test. So if you do think you have COVID and you do the rapid test and it's positive, you probably do have COVID. But if you do have a lot of COVID symptoms and the test is negative, especially if you do it fairly early after your symptoms start, it may not mean that you don't have COVID. In fact, it may be quite likely you do have COVID if it happens at a time like during a wave where there's a lot of COVID in the community. So, one tip is it can be useful to repeat the test a day or two later, and you may have a higher yield, but even with 2 negative tests, it still could be COVID. So it does make things challenging for sure.
Thanks, Matthew. Maybe I'll give you the next one as well, Matthew. Science Table has been dissolved, essentially. Mask mandates have been dropped. Vaccine mandates have largely been dropped. Are Ontario public health units and hospitals coordinating efforts regarding public awareness of the need for boosters and vaccines?
That's a great question. And just even before I answer it, I just want to make sure everyone knows that although the broad mask mandates have been dropped, we're still masking at Providence and at St. Mike's. And so it's still required that all staff are masked and that visitors are masked. And we don't always require patients to be masked, but we encourage it when they can tolerate it, and especially for our ambulatory patients. So still in healthcare, I think most places are masking. I can't say that I don't know that there's not some coordination going on in IRFAN. I might not be privy to it, but it's definitely something that should be happening, right? Like I do think we should be more aggressively promoting boosters as we head into the fall and winter, but I don't have a line of sight into what public health is doing. Certainly within the hospital, we're thinking about this. We're planning our annual flu campaign and trying to link it with the COVID boosters as well to really emphasize that for maximum protection this fall and winter, you want to have both vaccines.
Yeah, I mean, if I may add a little bit myself here, my own feeling is that the education and public communications on vaccine is not as good as it could be, right? In my ideal world, we would have the physicians associations, the nurses associations, the governments, the school boards, everybody singing from the same hymn book, encouraging vaccines and making it very, very easy for people to get vaccines. So, vaccine clinic after school or even during school, ideally at every school. There have been vaccine clinics at schools, but most of them are in the evenings or on the weekends, and they sort of seem like something that you can do rather than you really should do, I think, for many parents. There's still a lot of questions coming in, so probably 2 or 3 more, and then I think we will have to wrap up. Where was one I wanted to get to? How soon after having COVID do people get reinfected, and how prevalent are reinfections? Matthew, maybe I'll ask you that one.
Sure. So you're definitely protected after you get COVID for a period of time, especially if when we're in a phase where we're not seeing new variants. But there's not a magic number. We've often used 90 days in the hospital to as a sort of a rough measure where we don't really expect to see a huge number of new infections in somebody that was recently infected. But definitely when we switched over from the Delta variant to the Omicron variant, we were fairly frequently seeing people that had COVID, in 1 month and then COVID again 1 month later. So it's not all that common, but certainly could happen. And especially when variants are changing and when the new variant has some element of immune escape compared to the prior variant. But in general, you have pretty significant protection for 3 to 6 months. Maybe protection from getting COVID more for 3 months, and then protection from perhaps more severe COVID for much longer than that, which is really where those recommendations come in for the booster, that as that protection starts to decrease, that's when you're starting to think about getting the next booster. So it's nothing happens suddenly on day 90, but the week or 2 after you have COVID, you're quite protected. And then there's this decline over the next 3 months.
Yeah. I mean, personal anecdote, I got COVID in the summer just before I was eligible for my 4th dose. I was a bit annoyed that I did not, that it didn't happen the other way around. It was a more severe illness than I would have guessed it would be. I didn't need to go to the emergency department. I didn't ever feel like I was, going to die, but I was, felt quite unwell for several days. And if I could have had that shot before the illness, my guess is it would have been a much less severe illness. Maybe not, but hopefully it would have been a less severe illness. So I would have liked, I think if you can be up to date, my advice is be up to date. I think we're all on the same page about that. A follow-up to that question, Matthew, if you have COVID more than once, do we know whether you are more susceptible to long COVID?
Actually, that's an interesting question. I think what Fahad was saying earlier is the highest risk of long COVID is the very first time you have COVID, and especially when you're unvaccinated at that time, which is why there was so much long COVID early in the pandemic before there were vaccines and before almost anyone had COVID. So I think you're more likely to get long COVID with your first episode versus your second. My assumption would be, however, that each time you get COVID, there would be a smaller and smaller risk of getting long COVID, but you still would have an increased total risk. And I think there's still things we don't know about it. So there may be some things that predispose certain people to get long COVID and not others. And so if you didn't get long COVID with your first two episodes, maybe that means if you get a third episode, you're at lower risk. But the best thing to do is avoid getting COVID and taking the chance. I wouldn't guarantee that you couldn't get long COVID if you had it again.
That's good advice. Maybe given time, I will pose one more question that was in the chat, and maybe we can all try to weigh in on this one. And then I'll turn it over to Robin for some closing remarks. And then this is sort of the $1 million question that I think a lot of us have on our minds, which is the hospital, and I guess more broadly the healthcare system, equipped to handle another surge? Matthew, you want to go first, and then Fahad, and then I'll say something.
Yeah. So, I think the short answer is yes. Like I've just been amazed at what the hospital can do. The frontline, the nurses, the doctors, our environmental service people that are cleaning the rooms, our hospital administrators, they've worked so hard through the pandemic and accomplished, I think, really incredible things to provide care to people. So I have no doubt that they're going to find a way, but there's already a lot of pain in the system, and it's not going to be the best thing for every patient, right? So I had a kid that I thought had appendicitis about 6 weeks ago, and we spent a long time in the emergency room, like way beyond what I'd ever experienced before. And so the system is under stress, and that's only going to get worse with a surge, right? So will we survive a surge? Like, of course we'll survive. We'll do everything we can to help patients, but as I mentioned before, the resilience in the system, the ability to sort of suddenly have 20% more patients turn up is that's sort of long gone, and the system is really struggling to cope just with the current volumes. And we haven't really talked about it, right? But there's also been this huge impact over the pandemic of people not coming forward for care, and so all the knock-on impacts on the system that have occurred because maybe somebody's had a heart attack now that could have been prevented if they'd been having more regular medical visits with their family doctor and others over the last 2 to 3 years, and then that affects everybody downstream in the whole system. So we're not we'll survive, but I would say we're definitely not in the best place to handle a surge at this exact time.
Thanks, Matthew. Fahad, your views on that?
I echo everything Matt said in terms of the rallying that's happened within the health system. I do worry. I think I do have a real bit of worry around what this fall and winter will look like for hospitals. The hospital system has been used to rallying once a year in kind of early winter, late winter for flu season, but it's now been asked to kind of rally 7 times in 2 years for COVID surges. And I think a lot of the burnout that you're hearing about from healthcare workers is from that relentless pace, including just this summer, which is traditionally a recovery period for hospital workers. Just like the rest of society, people tend to take their vacations in August and get some downtime, and it didn't happen this year. It was again high pressure in hospitals, emergency rooms really stretched, delayed surgeries and procedures again. And so that system that has been under enormous strain, including just now heading into a fall and winter where the vaccination campaigns have not been great. So I think, heading back to our last question, the vaccine uptake has not been great. There is the big surge of infections that we had at the beginning and midpoint of this year, which are now 3, 6, 9 months ago. So that immunity from those infection waves are waning at the same time that the vaccination uptake has not been great. Plus, healthcare workers really stretched extremely thin. That makes me very worried heading into fall and winter. Those things coming together with even a modest COVID wave, not a bad one, plus a modest flu wave would be, I think, very, very tough for hospitals right now. We'll get through it. I just think that at each time that we force this through, data will show, I'm sure, once we look at this at a system level, that there were impairments in quality of care, that things were missed, that people were sicker than they should have been, or there was delays in treatment, all these things that it's not maybe directly one example, but it's the accumulated effect of many things under strain, which I think will show harm. But we don't know. And, you know, my best hope is that we just get through this winter without another bad wave. But right now, based on the pattern, at least with COVID, we've seen waves every 3 to 6 months. There's no scientific reason to think we won't see another wave this winter. And the flu data already from the Southern Hemisphere suggests that we will see a flu wave. So that's my worry. I know it's more pessimistic, but that's my worry.
I agree with both of you. I mean, I think healthcare professionals, nurses, doctors, everyone who works in the hospital will step up. They will work as hard as they can. They have through every one of the waves so far. And that translates into individual advice for everybody on the call and their families, which, is if you have a child who you are worried has appendicitis, or if you are having, severe chest pain, or can't speak or can't move an arm or a leg, you should still come to the hospital, and the hospital is the right place for you. And, you certainly will not be turned away, and people will care for you as quickly and promptly, as compassionately as they can. But I also share Fahad's view. We know countries where, where the data are kind of the best. And, the UK is one place where they keep very good data. It's very clear that when a health system is under strain, there is, what epidemiologists call excess mortality. And some of that is probably because people don't come to the hospital, to get back to what Matthew was worried about. So please do come to the hospital if you feel you need emergency medical care. And we know also that when there are staffing shortages, when there are more patients than can be safely cared for by the number of staff, the staff work harder, and they still care for all of the patients. But we know that the quality of care isn't quite the same. And this, best evidence suggests that mortality rates do go up a little bit. So I share some of Fahad's concern, and I also share Matthew's optimism and faith in the staff and physicians at St. Michael's in Providence. So that's probably a good place to wrap up. I guess I will just first say thanks to everyone for coming this evening, and thanks as always for your support of the hospital. And I'll turn it over to Robin for some closing remarks. And thank you, Fahad and Matthew.
Thank you, Irfan. That was so interesting and so informative. So big thanks to our doctors, Irfan, Fahad, and Matthew, and to all of you, our incredible community. We are so glad you were able to join with us today. We will follow up with a recap of today's conversation, and in an upcoming e-newsletter, we'll have a Q&A with Fahad as well. So look out for that. If you do have other questions that we didn't cover today, please let us know. Send those along to us. And please feel free to share the email that we send out in the coming weeks with your family and friends who may be interested. We look forward to hosting more sessions like this in the future, and we will keep an eye on things. I know Fahad and Matthew and Irfan will join us again if things continue around this COVID journey that we've been on. I can't believe we're still in this. I think I speak for all of us when I say it's quite amazing that we're still in this position all these many months in, but we're very fortunate to have incredible physicians and researchers leading the way and keeping us all safe. So thank you for joining us again. Thank you, Irfan, Fahad, and Matthew, and we will see you all again soon. Have a lovely, lovely evening. Thanks, everybody.